Hello, I'm Donald McCauley, and welcome to medicsvoices.com, where we talk to the key opinion leaders in health and medicine around the world. Today, we're in Florida, and I'm talking to Chip Mainous, who's one of the leading primary care academics. I want to talk to you about your career and how you got to where you are. But first, Chip, tell us about your name.
My name is actually a good Southern name. So I am Arch Mainous III. So there already is an Arch Mainous Jr. and an Arch Mainous Senior who has passed away. And so to distinguish us, rather than just continuing to name everybody the same thing, you start getting nicknames like Chip, Trey, so on. So that's how I became a Chip.
Well, Chip, tell us about your current post and your career to date.
So my current post is I am the Vice Chair for Research in the Department of Community Health and Family Medicine here at University of Florida. But I split half my time with the College of Public Health and Health Professions. I actually came here as the chair of the Department of Health Services Research Management Policy in the School of Public Health. And so I had a sort of switched how much time I had. When I was chair over there, I had this amount of family medicine. I've kind of even them out. So I'm sort of half and half. So I am really one of the people who sort of bridges between. And so before I came here, I was at the Medical University of South Carolina in Charleston, South Carolina, and I was the associate dean for assessment evaluation there in the College of Medicine. So I've moved around a bit, and but I like it. I like new things, and I guess I would say for my research and my areas of interest, I don't really like to have so many boundaries. So it helps me to have collaborators in all kinds of different places and to think about, is there a better way? Is there something new? Is there something else we can do? And pull stuff from different places. So that's how I do it.
What really interests me is what you described about the collaboration and the international collaboration, because you've done something that's perhaps a little bit unusual in US primary care. You've done a lot of collaboration with the UK. Richard Baker, Dennis Pereira Gray. Tell us a little bit about that.
Yeah, so I have worked with people in New Zealand. I've worked with people in the UK. I've worked with people in Haiti. We had collaborated with people in the Netherlands. So how did the original thing start? Actually, it was a good social thing. So I was at Wonka when it was in Dublin many years ago, and Richard Baker of the University of Leicester was presenting on some stuff on continuity of care, as was I, and he was the person who spoke right after me. I said, wow, that's kind of interesting stuff. I think I've seen your name. So we started talking. And then from there, got a grant and came over as a visiting professor to Leicester, ended up going down to Exeter. Then I got another grant where we did what I thought was a pretty novel thing. We compared diabetes care in the UK and the US, with the idea being, what does a universal access system mean for vulnerable patients, particularly minority patients? Do they do better in a universal access system than in a market-driven system? And you might have guessed they do better in the universal access system. But that was one. And then we also worked with Azim Majid, and then Sonia Saxena got involved. And in fact, I've been working with Sonia Saxena off and on for many years since then. Then at another conference, I connected with Nairi Kurse and the people at University of Auckland, went there, worked on stuff with them. So the Netherlands, that was an interesting thing set up by a fellow named Tim Stokes. He arranged a study to survey primary care physicians, family physicians in the US, the UK, and the Netherlands. And that study has been cited more than 2,000 times, which basically showed that doctors like continuity. They like seeing the same patients. So and I think a lot of times we forget that because we look at things like, how do we set up a clinic so it's easy access, and we think of activities like that, but it actually tends to move away from that dyad of one doctor seeing the same patient and building that relationship.
You said something very interesting, and that is about how the doctors like the continuity, because we've heard an awful lot about how patients like continuity. Now, I know you're interested in doctor-patient communication and have written about that. Tell me a little bit more about your thoughts on doctor-patient communication.
Well, I think doctor-patient communication is critical. I think that we tend to not give it the primacy I think it should. I think we look at health systems and say, the only thing that patients want is to be able to get in and out. They just want to be able to get in today, and that's that. But what we know is that building that patient-physician relationship is very important to the patients, not just in terms of their satisfaction, but we know they're more likely to adhere to treatment regimens. We know they're more likely to go along with recommendations for testing. And it also helps to coordinate care. So if that one physician plays that role of being the interpreter of all these other things for the patient, then they can do that. However, we could say, oh, well, the electronic medical record could do that, but I don't believe that's true. And there's data that shows that's actually not really the same. So I think it's very, very important. I think it's important if you have a good doctor. Okay, so I'm going to add that in. So we did a study, about 2 years ago, and what we did was we said, we know that patients like their doctors and follow what their doctors recommend. And what we did was we said, well, what happens if the doctor recommends something that shouldn't be recommended? Then what happens? So we looked at that time, we looked at data at the time when the U.S. Preventive Services Task Force had a guideline on prostate cancer screening. And that study was about the guideline was what was called a level D, which means don't do it. So the harms outweigh the benefits. So it wasn't a thing of, hey, well, I'll just talk to my patient and we'll see. So what happened was we said, what happens if the patient sees the same doctor, has this relation with his doctor, and the doctor recommends this? Well, guess what? Patients get it, but they're getting a low value test. And so I think we need to come back on that and sort of say, yeah, it's very important that we have that doctor-patient relationship, but it's also very important that we have very competent doctors as well. So there's two halves of that dyad, and they both have to do the right thing.
Now let's continue on this theme of communication, but on a wider sense, because you're a communication professional in the wider sense. You've worked with many medical journals, but you're also interested in direct communication with the public.
We're running into a real problem right now about communication. And so I'm going to link this back to where the personal doctor or the family doctor comes in. We, at least in the United States, I can't say so much for other places like the UK or Australia or someplace like that, but what I can say is that in the US, we're seeing an erosion of trust in medical experts, particularly government experts. So whether it's the head of the CDC or the Food and Drug Administration or anything like that, those things where people are trying to talk directly are getting lost, because what's now happening is that we're seeing, in terms of communication, we're seeing a lot of voices that are competing. So someone who runs a podcast, Joe Rogan, for example, has a huge following, and he'll give his opinion, and then the head of the CDC will give their opinion. The problem is now the patient is trying to figure out who to trust, who's most credible. And so I think that it's important that in many ways we talk about communication and we try to get those messages out, but we want to really, I believe, this is my opinion, we need to go through the family physician. What we need to do is get the guideline to go to the doctor to then go to the patient, rather than directly. I mean, that way you, with your patients, you can tell them, knowing their medical history, knowing their comorbidities, knowing their age, and so on and so forth, what medicines they're on, which might be contraindicated for something, then you can sort of interpret it. And you can say, I don't think now is the right time for you to do this, or I don't think this is the right test or this right trick. Now, we've been doing this for a long time in other ways. Direct-to-consumer advertising does the exact same thing. So every single time that you see, and I'm always stunned when I watch television, and they'll be say, oh, for those of you with non-small cell lung cancer, here's the right treatment. I'm like, you're going to decide what treatment you get based on an advertisement on television? That doesn't make much sense to me. But I think if we do that, we can get back to the trusted entity giving that information back out. That's my thing. I've done a lot of things with interviews and put stuff out, and I think it works. In fact, I know it works up to a point. But I also believe that there's a difference between scientists, physicians, and the government in terms of how people value and see the credibility of those three.
The idea of communicating on that trusted relationship between doctor and patient is so important, and the government message is so important. But it's interesting because you haven't been shy about engaging with the popular media. You've taken a couple of topics on in the popular media.
I have taken several on in the popular media, and maybe to my detriment. But though I think it's important to get out and say where I think it needs to go. I think the government is really in a crisis of credibility, and so I think it's important that academics, scientists can get it out. I also think that does another thing, which I think a lot of people don't see, is that someone like yourself also reads the media. So it isn't just reading an academic journal. You're also hearing this too. I think that it's important that we sort of separate out the podcasters and influencers from the people who have the expertise. I think if we do that, we're in better shape. So I try to say, look, I'm not a social influencer, but I do know something about this topic. And so this is where I think it should go. And so then we can kind of see what happens. So
do you think national organizations, colleges, international organizations need to be more active than in popular communication?
Oh, I agree. I think that's a very good point. I can tell you here at the University of Florida, they have media offices, and they come to me and they will say, hey, do you have any studies that we think are going to be big? And so I have one that's going to be coming out in January, and so we're already working on that. This is very important because I frame some relatively technical stuff into stuff that everybody can understand. But yeah, the universities need to do that. The universities need to go beyond just influencing their peers. So let me clarify this a little bit. When people start talking about your impact, there's really several impacts. There's several audiences that we want to look at. One is your peers, and so you can see that with citations. Okay, so you say, well, how many times is this article cited? But then we also have the idea that we need to get it out beyond that, out to patients, out to the public, out to the lay media. That's why when you see things like an article that might appear in the on the BBC, that's actually quite important. And so, or U.S. News and World Report, or the New York Times, those things are actually quite influential. So it's very important that we make sure that we do that, because that's getting it out too. So when you look at articles, and we can say, how many times was it cited? But we can also look at alt metrics and say, how many times was it mentioned in the media? How many other people talked about it? I think that's important too. Now, be aware, alt metrics and Reddit and some of that stuff can get a little off message in their discussions, but I think that's an important way to disseminate information from the experts, not the government. So I think, I just want to keep saying, there's a government, there's scientists, and then there's the physician. The patient-physician thing is I think it should be primary. But I think scientists also have to get their stuff out too, not just talking to other scientists and impressing other scientists.
So you talked about altmetrics and you talked about impact, which is a very nice segue into my final question, and that is, you were recently awarded the Maurice Wood Award for lifetime contribution to general practice family medicine. Tell us about that.
Well, yeah, that was that was quite humbling. I had to say, it was quite humbling. I've done a lot of stuff and on a variety of topics, but yeah, that was very good. So that was given by an international group and voted on by my peers. And you know, it was a very gratifying experience to say by my peers, you've done a great job. So because it was international too, as we talked at the beginning, I've tried to cultivate friends and colleagues in different places. And I think that, you know, that was very good. But yeah, no, I've done a lot of things. Some of it is, I think, is pretty high impact. Some of it, you know, it may seem narcissistic, but I think sometimes when you're out and you get in the media, it looks like, oh, you're just doing that because you want to be in front of everybody. I really believe that affects things. I can just give you a little example from years ago. It's not really about the Maurice Wood Award, but so years ago, working with Richard Baker, in fact, in Leicester, we did a study. This is about almost 10 years ago. We did a study on prediabetes in the UK. And at that point, there was no screening for prediabetes. That was not in the National Health Service. It wasn't in anything like that. And we showed that there were a lot of people who had it. And realizing that prediabetes is, if we talk about it in what it used to be talked about as, is basically just high risk for developing diabetes because it's just a lower level of glucose. And so a lot of these people transition. So it got a lot of press. And actually, it put me on to the BBC radio stations. So one was whatever the serious, super serious morning one, which actually hit me like at 2 o'clock in the morning. So I had to participate in that. But that had like the head of Diabetes UK and people like that saying this is a wake up call for the UK. Then they put me on one of the other stations with like a drive time thing. So they were playing music and then they stopped and they talked. So it was two different audiences, one and I thought it was fun, but I also when other people say these results are a wake-up call for the UK, I felt that like I think they're getting it. What I will say is, not to take full credit for it or any credit, is that within a year and a half of that, the UK started screening for prediabetes. So they didn't before. They hear this, they talk about all this stuff, and maybe there was a lot of other information they were already talking about, but they did after that. And I have to believe that there was some influence when the head of Diabetes UK says this is super, super important.
What's absolutely fascinating is your impact across the range from the popular media, the popular press, down to the individual accolade by your peers. And it's fantastic to see your name, and absolutely justified to see your name on the list of greats for the Maurice Wood Award. Chip, as always, it's a great pleasure to talk to you. Thank you very much indeed.
Thank you.